We are going straight forward and continue with my case. You remember the case? Christoph, 56-year-old, former tennis player, sponsor of my son, by the way, so that I had a quite good relationship to him. And I did it there 3 months after the primary implantation due to a very, very acute infection. After the day, he was great. He felt great. He went back to tennis playing. But unfortunately, in June, that means 6 months after the day, he came back and with severe pain and new signs of infection, slight fever. And the CRP was slightly elevated, not massively like before, 25 milligram per deciliter.
Was he still on antibiotics, Dustin? Was he still on antibiotics?
Sorry?
Was he on antibiotics the 6 months?
No, he was not on antibiotics.
What did the bacteria end up being? What was the bacterium?
The bacterium that we found was Staph epi.
Staph epi the first time.
Staph epi. It was not Staph aureus that we suspected, it was Staph epi. Probably it was a low-grade infection which come up.
Most likely it was there since surgery and it just gradually appeared, yeah.
Exactly. So, so after the DARE we administered just for 6 weeks antibiotics, and he was free of antibiotics since 4 or 5 months now. So, next step, Guvara, Christoph is coming to your hospital again. And what are you doing with him now?
I'll be tempted to offer him one more dare.
One more dare?
One more dare.
One more dare.
Because the X-ray doesn't show any osteolysis or any bug eating the bone. So I would like to give him one more dare with an adequate explanation to him that it may not work.
Okay. Ed, anything else? Some kind of diagnostics?
No, aspiration, get a DNA. Sometimes you pick up a second organisms. It's been interesting how the DNA sometimes will say, well, you said Staph epi, but there's a background player that may be persistent, and it may be one of those fastidious organisms that's never going to be cured until you take that implant out.
Dr. Henry.
Yeah, I agree. I would, more often when DARES fails with the second organism. And so I would not just assume it was the same bug relapsing, especially given how sick he was. It doesn't really match. I mean, Staph epis rarely present with sepsis like that. It makes me nervous.
Exactly. Dan, what would you do with Christoph if he comes to your practice?
Well, aspiration and make sure he's infected. There's other possibilities. Prove what the bug was. And then if he was infected, for me, this would be a 2-stage, but I admit that I know you'll do a 1-stage if you could do it. But having said that, most likely I would do a 2-stage with spacers.
Wait and see.
If he's infected.
Okay. Vijay, the same aspiration?
Yes, aspiration 2-stage for sure. Yeah.
What are you? We are not at the therapy now. Now we are at diagnostics. Vijay, if you perform the aspiration, what do you ask the lab for? What parameters do you want to get?
The cell count differential, and we also do a synovial CRP as well. That's our routine.
Okay. First of all, I would like to ask you, sorry, do you aspirate all your patients before any kind of revisions? Vijay?
Yeah, we do. Any revision, it's a protocol. So
even if it's a patient like this,
anything.
was a lady, polyethylene on the right side, 44 years after surgery.
But as a protocol, we aspirate all, and in fact, patients have got other implants inside, maybe a DHS or anything. Those patients also go in for aspiration.
Alberto?
I think the correct word here for what we do would be occasionally. So with us having over 30 arthroplasty surgeons, we definitely don't have an agreement. Dislocations, fractures, we do not. Everyone else who comes in with a chronic issue like osteolysis, ESR, CRP, certainly, and then go from there. We do. I would say not all of the surgeons routinely do it. However, as we sort of indicated yesterday, early loosening in a modern implant or patients with a metal-on-metal hip where you're concerned, that makes more of an indication.
So occasionally doesn't mean gut feeling, you have your strict protocol.
Yes.
Okay. Ed, this is another patient, but if you have such a patient who has a strong suspicion on the right side and he has a knee on both sides, or on a knee on one side and another hip, would you aspirate all joints, Ed, if you have a strong suspicion of extraction?
If the clinical exam of the knee shows no effusion, the knee is cool, I won't aspirate. If there's any inflammation by a milk test and you see any fluid whatsoever, I'm putting a needle in it.
Dr. Henry, what's your recommendation?
I know, I mean, I'm aware of there's sort of an evolving body of literature on this. You know, some of it depends on the onset of symptoms and whether I suspect it's a hematogenic spread or not. In hematogenic spread, I have a much lower threshold to aspirating multiple joints. I may consider, I mean, we sometimes are available to us PET scanning if the patient is inpatient. And that can be very valuable as a more sensitive nuclear test to pick up whether there's going to be inflammation in a joint or not.
Very good recommendation. Dr. Kumar?
Yeah, if there's a problem with the joint, then we aspirate, otherwise, no.
Okay. So we did a study about it, we published it, and we found significantly higher rate of metachronos, so-called metachronos PJI, in patients with polymicrobial primary PJI, Enterobacter, and diabetes mellitus. A very interesting question is, where do you perform your aspiration, Gugale?
I came to your endo clinic. I can't afford a room like yours. So I aspirate in the operating theater.
In Mayo, then, do you have dedicated rooms for aspiration or OR, or?
We have dedicated rooms for aspiration, but it's not the operating room.
It's not the operator, like us. Vijay?
Yeah, the C-arm is available only in the OR, so we do the aspiration there, but we need ultrasound, it's in radiology.
Dr. Henning, from your point of view, where should the aspiration be performed?
Well, again, wherever the surgeon says. But, you know, we do have, I mean, a large amount of our aspirations are done with interventional radiology, and they're done in a specialized suite. You know, I think that's probably the most accurate way. Plus, they can get additional information rather than doing it blindly in the doctor's office.
Okay.
I would say, by the way, that most people now are reverting to ultrasound guided as opposed to fluoroscopic guided.
That's the question here. How do you perform the aspiration at?
So I perform my aspirations in the office. I perform every single aspiration. If you do it a lot, you get to know the landmarks. It's ASIS, greater toe canter, isosceles triangle, angle in 20 degrees. Alcohol prep, dry, betadine solution, needle goes in, and the best thing that's been helpful is using a good anesthetic, wait 10 minutes, come back, and then you can probe and find exactly where you want to go, and that's how I go. It's interesting, remember that if you're using a lot of anesthetic, lidocaine or marcaine, that a DNA test will be deactivated by using lidocaine within the joint, just to remember that.
The problem is with local anesthetics, they could have a bactericidal effect. So
especially marcaine.
Yeah.
You got to go right to the joint, but not into it.
Vijay, do you perform your aspiration by yourself, or the radiologist is performing it?
Our radiologist, but we have a colleague who specializes in PJI, who's a consultant. So for all our different consultants, he's the one who does the aspiration all the time.
Can I ask all of you, who is performing the aspiration fluoroscopy guided? Who is performing it at ultrasound guided? Wow. And CT guided? Nobody. It's majority fluoroscopy guided. So, Alberto, which parameters, you aspirate your patient and you send it to the lab. What are you asking for which parameters?
So usually it's culture, cell count, and then neutrophil differential. We do not routinely do everything else you have there on the list.
We actually don't even have access to alpha defense in New York.
Alpha referencing,
We don't have it. I mean, it's,
you don't have it.
the outside labs are not, New York State has not approved use of the outside
What
labs.
about next-gen sequencing?
We don't routinely, I mean, we'd have to send it out to the Mayo or University of Washington or a few other centers. We don't do it routinely.
I think the interesting question is the radiologist will call us and says, I can only get half a cc out of this hip. What do you want? So typically, we've been sending it for culture. I've been making more of a push. Give me a cell count that's far more sensitive than a culture. And usually you only need half a cc. That's much more informative than a culture, which can be negative.
Okay. Dan and Mayo, what is your ranking? Let's ask for a ranking. What is most important parameter for you?
In general, it's going to be the culture, but I agree with you, under certain circumstances, a cell count with differential is helpful. So if you really are just trying to make a decision, do you think it's infected or not, and you're going to go right away, then I think a cell count with differential, if I had limited fluid, would help me more. But in general, if we are just screening somebody to make sure they're not infected, then the culture would be the priority if there's limited fluid. If we have enough fluid, obviously we do both.
Okay. Dr. Kumar, are any kind of molecular diagnostic tools available here in India?
Yeah, I think there are few, but we don't use it. So I'm in a public hospital, so but we have a biofire sort of test which is there now, and we do the PCR. So that is there, but that's not. It's very sensitive, but not very specific. You may say so. But again, you know, the culture is the main thing. Culture and cell count. These are the two things.
Dr. Henry, what do you think about molecular diagnostics?
Well, the problem with biofire is that, you know, the most common cause of chronic infection is going to be the coagulase negative staph, which is not on the multiplex panel, except for Staph lugdunensis, which phenotypically behaves as Staph aureus. So it's good for native joint. I think it's excellent for native joint, but you're going to miss a lot if you rely on that to rule things out.
I agree with you.
And it also does not have C. acnes.
I agree with you completely. BioFair is doing a very aggressive marketing at the moment, but unfortunately, they are missing the most common germs, and that's a problem. Okay, so here are the results of Christoph. He had an elevated cell count, neutrophil percentage. By the way, this is for me, number one, PMN percent, 86.5. Leukocyte esterase test. Who of you performing the leukocyte esterase test? That's a shame. Leukocyte esterase test costs nothing, a few cents. It has a sensitivity of about 93, 94%. You should use it. It costs nothing.
Can I ask you a question about that, Thorsten? They're derived from the leukocytes, though, right? So what does it tell you that the cell count with differential does not tell you? I understand it's faster. And you can do it at the bedside.
Exactly.
Is that why you're using it?
That's the reason why we are using it. You get immediately the result within 10 seconds or 15 seconds. It costs nothing. I agree with you. It's another addition. So, I mean, diagnostic is based on I would say, a combination of findings. And so serum CRP was 25. It was culture negative. Aspirated him, no growth. So then we go for some kind of treatment in chronic PJI. We have DARE, we have 1 stage, 1.5 stage, 2 stage, blah, blah, blah. What would be your option? You have a culture negative, proven, let's say proven infection. Dr. Henry.
I mean, in this situation, I think, at least in the US, where we are 2 stage, I don't know if you use 1 stage.
Agree. Yeah. Agreement. Guvara.
2 stage.
2 stage.
Ed.
1.5.
1.5. Could you, in 3 sentences, explain me what 1.5 means?
Definitive implants, very high dose antibiotics, removable cement.
What is the difference to a 2-stage?
2-stage is a spacer that you may buy that may become unstable within weeks, whereas a cemented implant that's definitive may last for years. If you have
What's the difference between that and a 1-stage?
Or a cemented one.
The dose of the cement.
It's the dose of the antibiotics. We went through this yesterday,
Yeah,
right?
right.
But don't you think that's a weird semantic? I mean, to me, that's just a one stage with high-dose antibiotics.
So what do you want to call a single stage with high-dose antibiotics?
Single stage with high-dose antibiotics.
So I agree with that, but if you want to write a paper and say something, how do you say high-dose antibiotics? You
Yeah,
just
but the
say
guys that are doing 1.5 stages, with all due respect, really aren't usually doing what you're doing, which is a really good job of cementing. They're doing a crappy job of cementing and then just hoping the patient never comes back.
And that's why I want to change it to say that a 1.5 exchange should be definitive implants, very high-dose antibiotics with a radical debridement. But that's my shtick.
Amar. Microphone 3, por favor.
The entire point of this 1.5 is you've got to cement it in well. It's
Cement technique.
yes, it's cement technique. And the beauty of it is if you're taking it out at some point, it's easy to take out or easier because there's so much antibiotic in it that cement is more brittle. But yes, it's not a crappy spacer. It is a definitive implant.
But you agree, at the end, it's a two-stage.
It's waiting to be a two-stage. That it's a race between the person dying and the second stage.
Do you know how the term 1.5 stage comes?
It's just a number. Like there's 1 and there's 2, so we went to 1.5.
I tell you the truth, it was a joke of mine. In 2017, I was invited from Rashid Tikhilov to St. Petersburg to give a talk about a new spacer. And the only, it's a long-term spacer. And I just wanted to find a funny title. So I said, 1.5 stage sounds quite funny. I was talking about a two-stage exchange. So, and since that time, publications look at so that's an origin.
But listen,
you are right. It's
but
a
even if
spacer
you
for
do-
long-term, for a longer interval. Yes.
Even if you do a two-stage, when you put your spacer in, I cannot stand it when people put in loose spacers. That spacer you should be able to walk on. It should be able to bear
Yep,
weight.
I agree.
And so you can, if you can get out a well-fixed stem, you can get out a spacer that's well-fixed.
The right term is 1.25, I think.
Exactly. So let's go prerequisites for one stage. What are your main if one of you would perform a one-stage exchange, what would be your prerequisites? Alberto.
Yeah, so for me, I think you actually put it here very nicely. You have to know the organism. If you don't know the organism, you shouldn't do it one stage. The issue is you'll take tissue cultures, you may only know the organism there, but if you don't know it preoperatively, you can't do it. And for me, I think sensible germ, this to me does not make sense. We define sensible germs by their species. Microbiologists go far more into detail for virulence and genetic markers. So I don't really know if we know what a sensible germ is. And then really a really healthy host. How we define that, though, there's very little consensus. A young, healthy person with a low virulence bacteria, this would be a good candidate for a one stage, in my opinion.
Okay, we have to...
And I think you want to talk about availability of oral antibiotics too.
Oral, yeah.
So I guess that's what you mean by sensible germ, yeah.
Absolutely. So now we come to another topic, fixation in one stage. If you perform, whom of you perform at least sometimes a one-stage exchange of the panel? Okay, 2 or 3. Always, Govara, always you fix your stem or your implant with antibiotic-loaded bone cement, or do you cement less revision stems, or some kind of a combination?
Combination.
Combination, that means?
If the bone is very osteoporotic, very capacious, DORS type C, I'll go and put a cement. And if it is, canal is amenable, I'll put on cementless.
Yeah.